Hello everybody, my name is Konstantinos Donas. I am a vascular surgeon in Münster, Germany. Yesterday I had the privilege to present for first time real-world data evaluation of patients with intermittent claudication treated by paclitaxel-coated balloon versus POBA. And it's very interesting that our analysis, having 5-year results, showed no mortality signal for the group of the paclitaxel. We performed a very sophisticated statistical analysis using propensity score matched statistical comparison between the two groups in order to have homogeneous group regarding the demographics, the age, which can influence the mortality. And based on this analysis, which was non-industry founded, I have to also highlight, we didn't observe any statistical significant differences between the two groups. So this was the first real-world data analysis, and I'm very curious to see now the opinion from Professor Frank Vermassen, University of Ghent, about these new findings. Professor Vermassen, these findings are in contradiction with the main message of the meta-analysis from Professor Katsanos. So what is now your opinion about this?
Well, first of all, I'm very happy that this study has been performed because finally what counts is the real-world situation and the real-world data. Yeah. Studies do not always reflect the real world. Secondly, I'm not really surprised because this actually kind of reflects our own experience, which we did not study so formally as you did, but the experience we have. Well, in my experience for 30 years as a vascular surgeon, I've never seen a paper that caused so much turmoil and discussions than the Katsanos paper on that mortality signal using paclitaxel-based DCB or drug-eluting stents. And when you look at the figures, they are there. I think statistically seen and mathematically seen, they are correct. But of course, you can only interpret the figures as you have them. And what we've learned from that is that well, probably there were several factors, also in the design of the studies, in the follow-up of the studies, which was not so complete as we would have thought they would be. All kind of let's say, interfering things and arguments that might have influenced the study. One of the main criticisms, and I think correct, is the fact that there is no causative relation, there is no cause found for that observation. You know, it's known that people that have a lighter in their pocket have more chance of dying from lung cancer. That's not because of the lighter, obviously. So there might be such a relation. It's not because you observe something that's the cause. So we really have to look in these things in more depth. Personally, I believe that in the following months, a lot of studies like you performed, also new results of randomized studies will become available. There are a few studies that will arrive at their 3 and 5 year mark and will give us new insights. And I hope with these results put together and new meta-analysis will maybe find other conclusions.
We are here in Spain, in Barcelona, during the SIRSE meeting. And it's very interesting to hear also from a Spanish colleague, Dr. Taneva, vascular surgeon in Madrid, in Spain. What is the practice here in Spain regarding DCBs? How was the impact from the Katsanos meta-analysis on daily practice?
Thank you very much, Professor Donas, for your invitation. I'm very glad to be here at SIRSE and share with you on my daily practice and actually the repercussion of this meta-analysis in Spain and I think generally in the world. Well, in line with several other societies, the Vascular Surgical Society in Spain also pronounced on the topic since there is a worldwide concern on whether the use of paclitaxel actually increases the mortality in patients treated for peripheral artery disease. And actually they gave several recommendations on the topic as for to avoid treatment in intermittent claudication patients and use paclitaxel treatment only in COI patients. They also gave recommendations to follow up these patients very intensively, looking for side effects or death, and have very good traceability of the patients as for type of device, length, and also reference number. At my institution and in my personal practice, we stick to these recommendations, and our current practice is of caution, awaiting for more data, for example, as your analysis, to actually see the role of paclitaxel treatment in our everyday clinical practice.
So we see, indeed, as you highlighted, Professor Vermassen, a tremendous impact on the daily clinical practice. We heard that here in Spain there is a clear recommendation only for CLI patients. So this is probably the result of this meta-analysis. So if we can summarize, we have from the one side the point of view randomized controlled trials, and we have from the other side the real-world data. We are saying very nicely internal due to the selection of patients versus external validity, which we have in the real-world data. So it seems to be the one with the other in contradiction, and for me as physician is important if I'm going to see tomorrow the patient having severe, I would say, claudication, let's say 50-meter walking distance. How would be your strategy when you are going to treat on the next day and you have an SFA lesion?
Well, both have their value. Real-world data have their value, and randomized studies have their value too. And you know, we have to, let's say, keep from each of these kind of studies the best thing and combine them to find our own decision and our own meaning. Personally, I still believe there is a place for DCB. The difference in patency was obvious. That's the reason why for CLI patients, although I must say these were often not studied in the randomized trials, for CLI patients where this patency is important, and that also the regulatory authorities think there's still a place. I must say, however, that the FDA, for instance, also thinks there is a place now, even now, in those patients with a high risk for restenosis when they have claudication. Personally, in our institution, we're doing a lot of studies with DCB, so we definitely go on with these studies because I think it's not a time point now to stop these. We need further information, we need more data. The studies certainly go on. And as for the rest, we inform the patient, as we think we should always do, but we continue using them in those patients which we believe are at a higher risk of restenosis.
So you are not going to use per se TCB in an SFA lesion, only in specific indications. Am I right?
The patients in studies are often randomized, that's one.
Okay.
And for the other patients, we, let's say maybe we're a bit more reluctant than in the past to use primary DCB, but we're still using them in those which we consider being at a higher risk.
And for your clinical practice, Dr. Taneva, you highlighted that based on the recommendation of the society, we have to use it in CLI cases. So for a patient with severe claudication and having an SFA lesion, you'll probably avoid to use additionally DCB, but this, based at least on the current published evidence, can influence the patency DTLR. Would you say, despite this, I would avoid to use it, or would you say depends on the lesion? What is the practice?
Well, this is actually the gap in the recommendations, right? Because
Exactly.
they are in line with the British recommendations and also the FDA. I would say Rutherford 3 patients, severe claudication patients, they have high risks to become CLI patients. And drug-eluting technology has proven to be a basic and needed tool to improve the results. It has proven in the RCTs that we have up to now its safety and superiority over plain PTA and over bare stents. So therefore, in this type of patient, in this specific group, I think we should use and perform the best shown treatment up to now for the patient, because their patients are at risk to go much worse.
So after the publication of this study, real-world data analysis, I had in my mind, now probably we have a change of the wind and we have a new, let's say, topic for discussion. But indeed, having this very interesting conversation with you, I'm realizing that probably we start now a new discussion about the importance of real-world data and how these can be generalized in general. So there is, of course, an ongoing process, it is an ongoing issue. I'm really pretty sure that we will discuss also in the future. But for the moment, I would like to thank you for the very nice roundtable discussion about an interesting topic. And I wish you a nice stay in Barcelona and have a nice meeting at CIRSE. Thank you again.
Thank you very much.
Thank you.